We're ready to go? All right, good evening, everyone. It's great to see all of you who have been able to, or are here to join us in person, and let's say welcome to all of those who are joining us virtually as well. For those of you who I haven't had the privilege of meeting, my name is Delvecchio Finley, and I have the distinct honor of serving as the current president and CEO of Atrium Health Navicent here in Macon, Georgia, and really excited to welcome you all here this evening for what is a very, very timely, urgent, and vital discussion for the health of our communities and more specifically for the health of our birthing mothers and our future. Let me start by offering my deep gratitude and appreciation for Mercer University, President Underwood, Dean Sumner, and all the other leaders for Mercer University for hosting us for tonight's event. I'd also like to thank our partners in this effort. As I mentioned before, Mercer School of Medicine, the Macon-Bibb County Health Department under Dr. Smith, and our Navicent Health Foundation under Ellen Johnson and her great leadership there for partnering us, again, for this important and timely event to raise awareness on maternal health and racial disparities that exist in our community, in our state, indeed throughout our country. Some of you probably know that Georgia, the state of Georgia, our beloved state here, has the second highest maternal mortality rate in the country. Not a list that we're proud to be on, or at least a ranking that we're proud to have. When we look further in the space of disparities, we have to acknowledge that black women in the state of Georgia are at 3 times more likely a risk of dying for pregnancy-related complications than other ethnic groups, according to the Center for Disease Control and Prevention. Maternal and child health is a high priority for the American Hospital Association, and indeed for all of us here. We've been hosting, or the AHA, tonight, has been hosting a series of sessions like this, where we're having dialogue and really calling attention to and heightening the awareness of the challenges of maternal maternal disparities throughout our country. We're encouraging conversations and interactions and engagement amongst a lot of key stakeholder groups. So our healthcare provider community, obviously, our social services professionals, our educators, our policymakers, and certainly women and their families, right, who we're all committed to serve and to address this issue of health inequities. It has been shown that toxic stress that mothers face both before and during pregnancy, things like microaggressions and racial inequities, certainly negatively impact the health of black mothers and their babies. We'll go a long way on our journey, or we're going to go on a journey tonight with a black mother through her story as represented in this film. And after that, we're going to have some real meaningful dialogue about what's happening here locally. So not just what's happening across the country, but in our state. We are looking, and I think I can speak for everyone here, to improve across Central and South Georgia the impact and the outcomes that we have for all mothers, and certainly those of color, and those in rural areas as well. Mothers giving birth to our next generation deserve this, and certainly our youth do as well. For Atrium Health Navicent, what I want to say is our mission is to improve health and wellness, to elevate hope, and to advance healing for all. And as a part of our social impact strategy, our teammates are working in our Family Birthing Center, in our Anderson Health Center, OBGYN clinics, to call attention to our own awareness of that role that we play in the continuum of the birthing experience for our mothers. So it's not just what's happening in our communities, but really what's also happening in our healthcare settings. So over the course of last year, we did trainings with our providers across our system in this area to bring awareness to implicit and explicit bias that actually happens in the healthcare setting, to bring awareness to the role that we have in that, to not just acknowledge it, but more importantly, to eliminate it, to address it in a meaningful way. So we're going to invite you tonight to listen to the story that we have before you here, and also to be actively a part of this dialogue, whether you're here in the room or online, both tonight and ongoing. But we also know that conversation is one one thing, action is another. And I know and I want to acknowledge that there's a lot of concerted effort across our community, and it has been for quite some time, to focus on and address these opportunities, but we also have to equally acknowledge that we have a lot more work to do. And so that's why we're here this evening, that's why you're here this evening, and we really want to keep that going so that we can have a real meaningful impact for our mothers and to improve maternal health. So now I'd like to turn it over to our next speaker, Dr. Wanda Thomas, Mercer University's Chief Diversity Officer. Ms. Thomas.
Well, hello, everybody.
Good evening.
I am Wanda Thomas, medical librarian and Chief Diversity Officer for Mercer University School of Medicine. We are honored to help sponsor this important gathering, and on behalf of Dean Sumner, who due to graduation activities could not be here, welcome. This is a critical, important initiative and something we as Georgians must address. Together with Atrium Health Navicent, Macon-Bibb County Health Department, and Mercer University School of Medicine, we must and will improve our state in the care of vulnerable minority patients. Mercer School of Medicine's mission is to improve the health of rural Georgians. Much of this issue of maternal mortality is related to the lack of care in communities who are marginalized, who have no access to care, and who have no voice. Together, we will be their voice. Please know the depth of our commitment and our intent to support this worthy effort is sincere. We look forward to working with you to improve the health of all expected mothers, but especially Black mothers of our state. And that's from Dr. Jean Sumner. Thank you. Up next to the podium is Dr. Patrice Walker. Dr. Patrice Walker is Chief Medical Officer at Atrium Health Navicent. Dr. Walker.
Thank you so much. So I will be moderating our journey for the rest of this evening. There's going to be 3 parts to this journey. We're going to begin our conversation with a little bit of background on unconscious bias. We felt that it's important to lay that as groundwork before moving into the viewing of the video. And then after the video viewing, we will then commence a question and answer interactive session with our distinguished panel members that we have here. And so we anticipate that this is going to be a very engaging evening for everyone involved. Just a couple of housekeeping items before we get into the unconscious bias discussion. I want to remind you that on the back of your program there is a survey, and those joining online, it will be in the chat. So don't forget, I'll remind you again, but please, we welcome your feedback with that survey. And also, when we get to the question and answer part, we ask those of you that have questions to approach the microphone that we have set up here. Those of you online will be able to post in the chat, and we'll make sure we try to get to some of those as well. So without further ado, we're going to go into the unconscious bias framework of the conversation. So what is unconscious bias, and why did we feel that we needed to put this as a foundation before we view the video tonight? It's one of the buzzwords that we hear a lot these days. You may also have heard it referred to as implicit bias. That's another term for the same thing. And what we mean is those preconceived notions and prejudices about people, places, or things that result in unearned positive or negative effects. Many times we tend to dwell on the negative effects, but there also can be some positive effects that come from unconscious bias. We want to get 3 objectives out of this brief discussion. Definitely want to describe the effects of unconscious bias in our interactions with those that may be patients, students, colleagues, other team members that we encounter in our day-to-day lives. We want to identify where personal unconscious biases may reside across gender, race, ethnicity, and or cultural attributes. So it's not just about race and ethnicity, although that's what we focus on a lot. And ultimately tonight we'll be focusing on maternal disparity in the form of African American women, but it's bigger than that. And then I am going to give you some specific bias-busting techniques that can be used not just in the medical and academic environment, but again in your everyday lives after you leave tonight. So why are these unconscious biases formed? They are mental associations that are really based on social norms and stereotypes. And I like to use an example that's not to do with people, but think about if you were, say, in the jungle and you were encountering an animal that you had never encountered before. We're all familiar with a lion, you know, but if you've never encountered a lion before and one walked in front of you, you would think to yourself, well, that's an interesting looking thing. I wonder what that is. When that lion attacked you, the next time you came into contact with a lion, you wouldn't think to yourself, I wonder what that lion is about. You would be running in the opposite direction. And unconscious biases are really our mind's way of trying to categorize all of those inputs that we have on a day-to-day basis. We hear things, we see things, we encounter people and places, and there's so many of those inputs that in order to process them, in order to even function, our brains try to put things into categories. That's not a bad thing. However, there can be negative consequences that come out of that if we're not careful. There can also be positive consequences as well. So we have to try and balance those things when we come into contact with them. What types of things influence that mental database of ours? Almost anything, but big categories like our ethnicity, our religion, our family, our culture, the environment, all of those things inform the way that our brain puts those inputs into the various categories. So the categories that I form may not be the same as those that Ms. Wanda forms, aren't going to be the same as those on the people on the panel. We all have our own unique spin on it, and it's influenced by these things that are listed here, as well as others. So why should you care? There are lots of reasons, and we're going to go over some of those, but big ones are that when we have biases, it leads to uniformity. And there have been studies done that show that there are better outcomes the more diverse our teams or groups are that we work on compared to cohorts that are less diverse. So when we have those categories and we tend to lump things together, we're actually doing ourselves a disservice when we do that. Now I'm going to go through some specific subcategories of how unconscious bias may affect you or may be affecting you. And some of these things are going to be really familiar to you. Others you think to yourself, never thought about it that way. What about a job or how we obtain our jobs? So let's think about an experiment that was done, and this was the real title of the experiment. Are Emily and Greg more employable than Lakeisha and Jamal? This was a field experiment on labor market discrimination that was done back in 2004. So this group sent out 5,000 resumes to 1,300 employment ads in Boston and Chicago newspapers. Each ad was sent 4 resumes. 2 of them were high quality and 2 of them were low quality. And they were randomly assigned a very African-American sounding name, such as Lakeisha or Jamal, to one high quality and one low quality. And the other had very white sounding names like Emily or Greg. The jobs were in sales, administrative support, clerical services, customer services, and the quality piece of the resume varied in things such as experience, holes in their employment history, email address, etc., etc. So what do you think happened? Well, for 2 identical individuals engaged in an identical job search, the one with the African American name would receive fewer interviews. Applicants with the white names needed to send 10 resumes to get 1 callback. African American applicants needed to send 15. And that 50% gap is statistically significant. Remember, there was no difference in the resumes other than the name on the resume. So at the end of the day, that white-sounding name yields as many callbacks as 8 years of experience on a resume. Now, this is just one, example, and one could criticize how it was done, but I think it really sends home the point that there is a lot in a name. And that is something, in the African American community that there's a lot of conversation about. And I will have to tell you that it certainly influenced the name that I picked for my daughter, even. There are only so many things that you have control over, and I wanted to make sure that those things that I do have control over, we do have control over, we use those things to our advantage. And yet the flip side of that is you should be able to name your child anything you want, but we don't live in a society where that holds true. What else could it affect? It could affect your bottom line. We all understand how much we bring home affects our ability to enjoy life and even just function and have the things that we need. In 2015, women earned 83% of what men earned, and this was according to a Pew Research Center analysis of median hourly earnings of both full-time and part-time U.S. workers. The Census Bureau found that women earned 80% of what their male counterparts earned in 2015. Now you may wonder, 2015, should she update this slide? Well, I told myself that I was going to update that slide as soon as I could because clearly that was not going to continue to be the case. Well, guess what? It's still the same today. So that's why the date is what it is. I'm not going to update that slide until there's a change, and it's essentially stable. That for every dollar that men earn, women earn 80 cents, doing the same matched job. What about feedback? Many of us in this room are in a position to give feedback on many things. We're asking you to fill out a survey at the end of this event that we're having tonight. Your unconscious biases can definitely affect the feedback that you give, not just on something like an event like this, but on an evaluation of a student, on an evaluation of a coworker, an evaluation of someone that you are trying to determine whether or not you want to be a vendor for you. So a lot of the things that we don't know that we're even being judged on, unconscious biases can have an impact on those things. And finally, since I'm in healthcare and several of our panelists are as well, we definitely know that it can affect patient care. A study done by Stanford, and actually I left the date off of this, but it was several years ago, showed that 2 out of 5 medical students actually have a bias against obese people. Those biases include thinking that obese people are lazy, and the reason why they're obese is because they are lazy or don't want to do the work of exercise. Clinicians may order fewer tests or perhaps even the wrong test if they don't understand a patient's description of their symptom. And I will give you a personal example. I'm going to give you several personal examples over the course of the next few minutes. I remember a particular time so I'm an OBGYN by training, and when I was in my residency as OB interns, we have to do a rotation in the EC, in the emergency department, emergency center. And in that rotation, you not only see women, you see men, you see whoever walks in the door. So there was a particular encounter where there was an older gentleman who came in, and I was told to go see the patient. So I went in to see the patient, and I said, "Sir, what brings you in today?" And he said, "Doc, I'm all stove up." I had no idea what that meant. So you got a fraction of a moment to decide, what are you going to do? I didn't want the patient to know that I didn't know what he was talking about. And so there are a couple of things that are running through your mind. You just keep going and say, oh, okay, well, let's run some tests and we'll try to figure that out. You fall back on the good old, tell me more about that. That's always a good one. Or you go out into the hall and you ask the nurse. That's never the wrong answer either. So lots of options, but does anybody know what being stove up means?
Constipated?
He was stiff. He meant that he was stiff like a stovepipe.
Oh, I thought he meant he was constipated.
So if you didn't understand that,
No.
you could be ordering all kinds of wrong tests and doing all kinds of things. And so that's a funny example, but honestly, that really does happen, to this day, because in certain situations, we don't want to show that we're vulnerable. We want to make it seem like we're competent, and so as opposed to just asking for more information or asking for the appropriate information, we try to cover, and that could lead to misdiagnosis, underdiagnosis, and part of the reason why we're here today. And what about our LGBTQ community? We know that lesbians are actually 4 times less likely to have undergone a mammogram in the last 2 years than heterosexual women. Why is that? It's based on what they look like. And in many cases, they don't fit the normal idea of what we have in our minds of what a feminine woman should look like. And we base our interactions simply off of that. And so those are the types of unconscious biases that we are up against in healthcare. And that's just a very few examples. There are many of them out there. And until or unless these things are really brought to our attention, we continue to struggle and continue to have these happen over and over again. So let's dive in. We're going to do a quick activity, because the first key to combating bias is to recognize it, and every single one of us in here has it. So we're going to do a quick activity that should help you see some of your own biases. So what you're going to do is I'm going to show you some pictures, and you're just going to have a few seconds to rate the following individuals on a scale of 0 to 10, 0 being none, 10 being the most, on 2 elements, on your perception of their compassion and their competency, overall competency just as an individual, okay? Now, I do have to give credit to this activity from one of my colleagues back in my days as a Dean of Diversity. I did awful on this activity, so I'm very interested to see how you guys are gonna do. All right, this is your first picture. Just a couple of seconds. Remember, in your mind, think to yourself, how compassionate does this person look? How competent do they look? Compassion, competency. Next. And you're rating on a scale of 0 being none, 10 being the most. Compassion and competency. You may recognize some of these. If you do, that's good. Don't yell it out. We're going to go over it in just a minute. How compassionate or how competent do you think this individual is? Next one. Who is calling out answers out there?
I apologize in advance.
And one more, last one. All right, now we're going to go over answers. So we're going to reveal who these individuals are. And remember, this is about your own self. So when I told you that I did horrible on this, it's, I thought to myself, I'm well-versed in this sort of thing. No. It's amazing how quickly we are able to, put people in a box. So what did you think about this one? Do we think he looks very compassionate?
Of
What makes us feel that maybe he's not compassionate?
15.
What about that? He's got that tattoo
Prison tattoo.
on his arms.
Prison tattoo.
Prison
That's his
tattoo.
area code.
Prison tattoos. Does anybody know who this is?
He's an elected official.
He is. This is John Fetterman.
Yeah.
He's Lieutenant Governor of Pennsylvania. He was elected in 2019. Before that, he was the mayor of Braddock, Pennsylvania. For 3 separate terms, he got reelected. He has a BA in finance from Albright College and a master's of public policy from Harvard. What's that number on his arm?
It's a zip.
Zip code.
It's the zip code for Braddock, Pennsylvania. He is very articulate, but if you just look at him, so my first thought was what many of you in here thought. I thought, well, he looks like an ex-con. Little did I know. All right, what about this one? She looks wise. She looks wise, knowledgeable. I thought she looked
Gandhi a little bit.
Gandhi, okay. I thought she looked very caring, like a grandmother. You know, she's someone that I want to cook. I want her to cook for me. You know, that's bad, but that was in my head. Does anybody know who this is? This is Prativa Patel. She was the first female president of India from 2007 to 2012. Very competent, very intelligent. She's a leader. What about this one?
Isn't it Ted Money?
Quite competent, yes. So what got me was the crinkles next to his eyes. I thought, well, he just looks happy. Those eye crinkles, he looks very nice. Who is this? This is Ted Bundy.
Yeah. That's what I was like, he's a serial killer.
Prolific serial killer. So he killed at least 30 women, probably more that we did not find. Maybe the black and white picture gave it away, but it was something about that picture that I thought, well, he looks competent. He looks, again, I think of those eye crinkles and I think jolly, you know. But yeah, he's not.
Kind of a news anchor.
News anchor, yeah, he's got on that suit and tie. This one, that is Mae Jamison. Yes, so she's an engineer, a physician, a NASA astronaut. She was the first black woman in space. So that the lower picture is the one that probably you're used to seeing from her younger days. All right, last one. You may not be as familiar with this last individual. Does anyone know who this is? Or what were our thoughts? What were our thoughts about compassion and competency? Approach him with care. Okay.
Eyes look a little shaggy.
Look shifty. Shifty. That's an interesting term. So this is Jamison Green. He is a transgender male, a lawyer, an educator, and policy advisor on transgender issues. So interesting use of the word shifty. So transgender, for those of you that get confused about, is that when we say transgender male, you can always remember they're transitioning to male. So when you see transgender male or transgender female, turn transgender into transitioning to male or transitioning to female. So he was born female, but he transitioned to male. So this was just a quick exercise, a lighthearted and fun exercise, but honestly, this is something that we do every single day when we encounter new people that we've never met before, and you're gonna see more of this in the video that we're getting ready to watch here in just a few minutes. So let's quickly move through the various types of biases. Stereotyping is something that we are all probably familiar with. That's a word that we hear all the time, where we use these broad generalizations to make inferences and judgments about people, places, or things. Affinity bias may be something that we're not as familiar with, but that is when we prefer people who are similar to ourselves. This type of thing happens when you meet someone who went to your school or was in your sorority, or something connects you to that person, so you're like, oh, they are automatically good people. That's affinity bias. You don't know that yet, right? Blind spot. Blind spot bias is when we recognize other people's biases and not our own. And that's a big part of the reason why we wanted to spend some time talking about unconscious bias before we watch the video, because it's very easy to sit here and think, well, I would never do that. But you do, you would. Confirmation bias is the tendency to accept evidence that confirms our belief and reject evidence that contradicts them. So examples of this are global warming. You know, there are some people that just don't believe it's happening. You know, that there are some people that will reject scientific evidence. I mean, we just went through an entire pandemic where there were people that did not believe that COVID-19 was a thing. They did not believe, you know, vaccines, all the scientific evidence, but they confirm, or they accept evidence to the contrary of what is truly factual. And then there's groupthink, and that's when we're vulnerable to taking the opinions of the group instead of offering a dissenting opinion. So this is what I like to call when we go along to get along, right? You're in a group of people and there's this conversation going on and you're thinking, I don't agree with that, and yet you don't voice that opinion, you just sort of say nothing, or you might, you know, nod and agree when in actuality, you know, you don't. So now I want to give you some tools to use to try and combat some of these biases. And these tools are just like anything else. It's just like a muscle. If you don't use them, you lose them. This is not something that's going to come naturally, because we're fighting against the way that our brain has worked, you know, for our entire lives. And in many cases, it is a functional part of ourselves that we need. But we've got to be able to recognize when we are being dysfunctional. And so these are a few strategies to help you in mitigating some of the unconscious bias. Perspective taking is when you take the perspective in the first person of a member of a stereotyped group. So these are two cartoons. These are two of my favorite cartoons that I always like. The one on the left, you see that these two people are thinking not from the other person's perspective, but from their perspective. So the individual on the left is saying, oh my gosh, everything covered but her eyes. What a cruel, male-dominated culture. The other individual is thinking, nothing covered but her eyes. What a cruel, male-dominated culture. So they have the same perspective, and yet not exactly. And then the cartoon on the right is one that I really, really like, because it is very familiar to anybody who's been in a situation where you are perhaps the minority or the, you know, person of lower status. So you've got two eagles here conversing, and the one eagle says, do you think the owl is a predator? Of course not. It's never bothered me. Exactly. I have no idea what Mr. Mouse was going on about. So, an owl is not a predator to an eagle, but to a mouse, it certainly is. And so, you've got to put yourself in the shoes of the other person. When we approach things from our own perspective, we are really missing the point. When someone brings a concern to us, their concern is valid to them. Whether or not you perhaps agree with it personally, that does not negate the fact that it is truly a concern. Individuation is similar but different in that we obtain specific information about group members to evaluate members of that target group based on personal rather than group attributes. And that is, you know, as opposed to seeing a individual like a Trayvon Martin, you know, you take him for what he is in that moment, not based off of the group that he is a part of, being a young black male in a hoodie. Then practicing the camera exercise is so important, and that is exactly what it sounds like. When you look through a camera, you look at it and you can only see or say what it shows. Everything else is an interpretation, but is not fact. So when you look at this picture, what do you see? You see an individual with a young child across their lap and their hand in the air. That's it. What you want to think is, well, he is getting ready to spank that child. You don't know that. And this has happened to me more than I would care to admit. I have walked into a patient room, now I'm an OBGYN, remember, I've walked into a patient's room for an OB visit, a new OB visit, and there's a young individual, you know, sitting there, and there's another female, a young female sitting there, and there's another female in the chair next to her, and I go in and I say, well, hello, how are you? And you brought your mom with you today? And she looked at me and she said, this is my partner. Open mouth, insert foot, right? And it just came out, and I just felt like, how could you have done that? But, you know, that is what we're up against. So you walk into a room and you're immediately interpreting what you see, and you don't know that. So lesson learned from that is I walk into a room and I go, and who have you brought with you today, right? So those are just a very few strategies for change. So I know I went through that really, really quickly, but we've got to move on to the next part of our show. So I do want you, if you don't remember anything else, I love this quote by Linus Paulding that says, do unto others 20% better than you would expect them to do unto you to correct for subjective error. Just in case. So now we're going to transition over to our video. Toxic, a Black woman's story, and Del Vecchio really explained why we're here today very well. You know, we know that African American mothers are 3 to 4 times more likely to die from pregnancy or childbirth-related causes, and we know that Black babies die during the first year of life at twice the rate of white babies. But why? Why is that? We're going to delve into that briefly, but it really goes into the inequities. Inequities are like a substrate that women must navigate as they live, work, and play. And some women, that substrate is like air. It's very thin. It's basically nothing. Some women have little rain showers to get through, and then there are others that literally have to avoid landmines in a hurricane. So as you watch this video that we're transitioning to, I want you to keep in mind that substrate that the main character is going through and how that affects her and how it really affects, you know, all of us, whether or not we are mothers or are going to be mothers. So with that, I will we'll transition over to the video, and our panelists can take a seat in the front to watch this video. Great.
Baby, can you go wake Michael up for me, please? I gotta get ready. Please, come on. Love you, thank you.
So you want to get a couple shades lighter than your own. You doing your homework?
Doing your work?
I'm almost done.
So am I.
Okay. Don't let your mom see you. She's gonna say something to you.
Good morning. Michael.
Good morning.
How are you?
Hey. Get you some breakfast.
Wait, that better not be your homework.
I'm almost done.
What do you mean? What were you doing last night?
I was working on it.
Michael, done?
Now, on to our top story. A 12-year-old boy was shot and killed by a city police officer Saturday morning. According to the officer's statement, the boy was wielding a BB gun that the officer perceived to be a firearm. When asked to comply,
Gosh, come on, you guys, not today.
Damn. Okay.
Don't.
Yes, I will.
I don't know about this hair. Like, what do you do?
You gotta let that skin glow and that hair grow.
Oh my gosh.
Wait a minute. Is that the skirt that you had on that one? That you had on
I
the
know
night
you're not
that-
gonna talk like that in front of your son.
Anyway, did you take your vitamin?
No, not yet.
How'd you sleep last night?
Okay, I guess.
Guess.
Yeah, I mean, I had a little pain, but nothing too bad.
Should we call Dr. Gupta?
Why? So she can just dismiss whatever I have to tell her like she did last week?
You went to see her last week? Why
Yeah.
you didn't tell me that?
It was nothing. I just had a little pain, that's all.
You still gotta tell me that kind of stuff though.
It was nothing.
How have you been doing?
To be honest, not too good. I mean, I've been having a lot of pain and cramping in my lower abdomen.
Yeah?
Enough that I thought I should come in and see you.
Sounds like round ligament stretching. Pretty common.
I just don't remember having this kind of pain with my first baby.
Nina, I know this is not your first pregnancy, but I'm sorry to tell you, not all pregnancies are the same. It's not always comfortable, and plenty of women overreact to these things.
Overreact? I don't think I'm overreacting.
Everything is fine. Just go home and treat yourself to a relaxing evening. I'm sure you'll be feeling better soon.
Wait, but is there anything that you... Oh my God.
Go to the doctor.
Thank you. No, I mean, besides, I don't know. I mean, I have the depositions today and that big trial. I don't have time for a doctor today.
So then we need to talk later.
Okay.
Oh, by the way, I got a late meeting today, so can you pick up Michael from school? I can just grab some dinner on the way home.
Okay. It's not like I just literally didn't tell you how swamped I am today.
I got it.
No,
I'll
it's
do it.
fine. I can do it. Just tell me what time you'll be home. I know you know better than that.
Sorry.
Just for that, you can say grace. Come on. Let me tell you twice.
Thank you, God, for this food, for rest and home, for everything that is good, in the wind and sun above, but most of all, those we love. Amen.
Amen.
Let's eat items. All right.
When we get home later, I want you to put your wrestling clothes in the washer. What time are you getting out of practice? Michael, are you listening? Michael, I'm talking to you.
I heard you.
Well, what time do you get out of practice?
4, but we're going to the skate park after.
And who's we?
Me, Jamie, and some other kids.
Are any parents gonna be there?
Parents? Why do we need parents? We're just going to the skate park.
another day of protests downtown today after the shooting of a 12-year-old African-American boy who police say was wielding a BB gun.
Sorry, not today.
Why?
Just not today, okay?
God, it's so unfair.
You're right, it is unfair, but I'd rather you not have to find out the hard way when you and your friends are picked up and you're the only one going to jail.
I'm just scared because of the news. We're not going to get shot or anything.
Enough, Michael.
Still talking digits, take a house and flip it. And if we talking squares, I'ma need 20. Coming down I-20, no ludicrous. Took them 20 blocks and turned it into 60. I'm talking hush money, don't come slow, it come fast. When you running through blocks, you run through pounds, smoking gas. I said so hush, money keep coming stacked up like a bus. Yeah, I'm really getting money, me and bread got a crush.
I love you. Mango.
Good to see you here today.
Hi, how are you?
Got a minute to talk?
Actually, I'm in a bit of a rush. Is everything okay?
Yeah, well, there's just a problem with Michael's wrestling.
Oh?
Yeah, it seems he's going to have to do something about his hair if he wants to stay in the program.
His hair?
Yes, well, I guess there's a league rule that says boys can't have dreadlocks. It interferes with the matches.
He's wrestled in dozens of matches. It's never been a problem before.
Well, I believe it to be a new rule. Well, some of the other parents have been complaining about the lack of enforcement of the rule.
So does this mean all your boys with locks are having to cut them?
No, just Michael.
Oh, just, okay. Well, I'm gonna get going, but I will definitely talk to him and his father tonight and get back with you as to what we decide to do with our son's hair.
Of course, and I hope this doesn't seem like it's anything other than policy.
No, why would it?
Right.
Have a good day.
You as well.
Have his locks forever. Talk to me about his hair being a problem on the team. It's just unbelievable. Wait till I tell So does this mean all your boys with locks are having to cut them?
No, just Michael, just Michael. Hey, some of the other parents have been complaining lack of enforcement of the rule.
I hope this doesn't seem like anything other than policy. The policy.
Morning. Good morning, Nina.
Oh, hi, good morning. How's it going?
Well, I know Carl called us here for this meeting, but I think I'm missing a couple of things on this Dan's case.
I'll give you everything I have.
All right. Let's see what we got here. So, have you seen the new intern? I was 20 years younger.
And what would your husband say about that?
Oh, I don't think he'd mind if I was 20 years younger. Oh, are you okay?
Yeah, I think my little mango didn't like what I ate for lunch.
I love mango. Did you have it in your salad?
No, not. Never mind.
At least you're over the morning sickness part.
True.
I remember with my first two, I was sick all the time. The third one, I didn't feel a thing. Though she's the one who gives me the most trouble of the three, there's some irony in there.
Did we get any word back on the Blair case?
Nope, still waiting to hear back from the judge. Oh, did you hear about the Williams case?
Hear what?
Well, Leo managed to get a sentence reduced down to community service plus probation.
Are you kidding me? "18-year-old frat boy rapes a passed out girl and gets probation? Because he is a promising college kid who made a mistake and his life shouldn't be ruined. Meanwhile, my pro bono client, who's only 16 by the way, finds himself at the wrong place at the wrong time with the wrong crowd with no idea that he's sitting in a getaway car. Now he's being tried as an adult for armed robbery and had nothing to do with it."
Well, yeah, but he's from Kinsman. Nothing good ever comes from Kinsman.
I'm from Kinsman.
You know what I mean.
Yeah, I know what you mean.
Anyway, there's probably more to it than that. He might have gotten in a fight with the police or had drugs on him or something. Oh, I forgot to tell you. I went to that soul cycle class yesterday, and guess who the teacher was? It was that woman with the crazy green and pink hair. And she was telling me this story about her cat. How her cat has learned how to ring the doorbell in order to do that in. It's such the craziest thing, isn't it? I mean, that's funny, right? Nina? Funny, right? Nina?
Hey, now let's go.
Who was that?
Who?
With the long hair?
Riley?
Does he wrestle?
Yeah.
Here?
Yeah.
Got the nerve to talk to me about some hair today.
I'm hungry.
I can't control the traffic, Michael.
Can we stop and get something?
Your father's picking up dinner. Can't you wait?
Is that for you?
Oh my gosh. I don't know.
Was you speeding?
No. I'm doing like 30. Like, this is crazy. There's no shoulder. Guess I'll get off right here. Great.
I thought we was gonna get a DWB.
What is that?
Driving while black?
Right. It's crazy.
Want me to look for directions back on the highway?
No, I know these streets.
I mean, we were just sitting back, chopping it up, reminiscing about the good old days and all that. Tracking my roots, where I came from and where I'm going. But like I say, man, always said it.
This place is shelby as
Boy, you better not finish that sentence.
Sorry. Oh, can we stop and get some?
Here?
Please, I'll be quick, I swear. Please. Before we pass it, please.
All right, but be quick.
Quick.
I mean, real quick.
You put a baby on top of that baby. Hey, let us do this shot. What you mean?
Do you guys have any fruits or granola bars?
No fruits.
I understand about the fruits, but do you have any granola bars or power bars or something like that?
No granola.
Still keeping this place stocked with healthy options for the community, I see.
Sir, do you have any quinoa by chance?
Don't. No, you don't.
Swipe your snap card.
What? What's that?
Do you have a snap card?
No, I don't.
You ask everyone.
So that's not his name?
No, it is, but not when he raps.
Well, what is it when he raps? Childish Gambino? Let me get my candy. Childish Gambino. Childish? How old is he? And what is a Gambino? I mean, what does it mean?
I don't think it means anything. He came up with it on some Wu-Tang name generator. Wu-Tang, it's a group from the 90s.
I know you're not trying to teach me about Wu-Tang.
Yeah.
As we dwell in this concrete hell, calling it home, Mama say, take your time, young man, and build your own. No mind up like your own dad. Still searching for the glory days he never had. What are you trying to teach me about Wu-Tang?
I thought you only listened to jazz.
Listen, honey, I've been shadowboxing since before you were born.
That's pretty cool. I ain't think you had it like that. Mom.
Oh.
You okay?
Oh. Call your dad, man. Call your dad. Oh. Call your dad.
Hello? Dad, Mom's in pain.
Here we go. I need you to give me a good deep breath and let's go. Yes, come on, Nina. That's good. That's good, Nina. That's good. Okay, I can see the baby. It's coming up. Very good, Nina. That's great job. Great job. Great job, Nina. Nina, I'm going to give your baby to the NICU doctor so that he can take care of him and I can take care of you, okay?
Baby, okay. Baby, okay.
Nina, he's going to be okay.
How's our chest rise?
I've only got on one side.
Let's adjust the breathing tube.
The heart rate is dropping.
Let's start chest compression. Let's start chest compression. Let's start chest.
lived and too young and died. To my people I salute in the sky. And I can't fade your memory, pain still continually. I admit sometimes I cry. Now this is dedicated in the memory of, to my people up in the sky. Loved ones watching from above, had an impact, purpose for they vanished from the...
All right, so that's not the first time that I have, of course, seen that video, but every time that I watch it, I go through a range of emotions. I see myself in that video in many ways. I see women that I have taken care of in that video in many ways. I see my friends, my family, interactions that we all have on a day-to-day basis. So now is the time for dialogue during our program. We have some questions that are already posted for our panel members, but also remember that for those of you in the room that want to have questions answered or even just say comments, we have a microphone here. And then also remember, if you're online, you can place questions in the chat that we'll also try to get to. Let me take a minute to introduce our panel members today. We have a diverse panel of experts, starting first with Dr. Jacob Warren, who is a behavioral epidemiologist and health equity expert. He's the chair and director of the Center for Rural Health and Health Disparities at Mercer University School of Medicine. Next to him, we have Dr. Jimmy Smith, who is a physician as well as has his master's degree. He is an administrator for the Macon-Bibb County Health Department and has experience in general family medicine, public health policy and administration, minority health and health equity and disparities issues. Next to him, we have Ms. Patricia Prime, who's a nurse and owner of Prime Baby Time Consulting. She is also an international board certified lactation counselor and a certified postpartum doula. And finally, we have Dr. Felicia Love Kitchen, who is an OBGYN. She is the OBGYN residency program director at Atrium Health Navicent, and also completed her training there. So thank you very much, panelists. I want to start with a question, and I'm going to start with Dr. Kitchen, who, as an OBGYN similar to myself, and we've already seen the statistics. I shared some in my presentation, and some were shared also at the end of the video. But we know that African American mothers are 3 to 4 times more likely to die from pregnancy or childbirth-related causes, and we know that Black babies die more during the first year of life. What do you think is happening in hospitals and clinics to contribute to this rate?
All right, so actually this is kind of a multifold problem. So African American women, we have a higher rate of having hypertension, diabetes outside of pregnancy, and a lot of times we bring that into pregnancy. So it's not actually taken care of very well before a woman gets pregnant. We also have, as African American females, have a lot of stressors that other races don't seem to have. And as noted in this short film, external environmental things really do affect our patients and us as Black women, which can contribute to some of these cardiovascular disorders. I think Dr. Smith would agree with me that stressors can affect a person's blood pressure. With that also being said, there's also patients not getting the health care before they get pregnant, but then they're also not getting the health care that they need after pregnancy and then come back pregnant very quickly again. And we call that SIPI, short interpregnancy interval. And all of that really culminates into what can be a catastrophic situation. And then you have healthcare providers that don't typically look like us. I was reading some really startling statistics of all OBGYNs in the US. probably about 64% are white, which is very common and which is very reflective of our national landscape. 18%, almost 19%, are Asian, 9% are Latino, and 5% are African American. That does not match our national landscape. And so one of the biases that Dr. Walker talked about was an affinity bias, and patients do have an affinity bias. They are more apt to, they're more welcoming to answer questions and to relate to physicians that look like them. So that's a hard question to answer in just one nutshell, but I think there are many factors that we have to look at in this situation.
Thank you for that, Dr. Kitchen. What about Ms. Prime? How, in your opinion, can providers better support the pregnancy and birth needs of African American women, taking into account what Dr. Kitchen just told us?
I think just one word, listen. We have to, I think that physicians have a responsibility to listen to the patient when she comes in to the office for care. And then I also think that the patient has a responsibility to request or require that physician to listen. Care doesn't start when the person is in trouble. Care starts at the very beginning. So being consistent with your appointments, having the right attitude, with your appointments, being on time. If you're gonna be late, call. Just kind of establishing a relationship with the front desk staff. But when you go back to see your provider and you have questions that need to be addressed, you should require them to listen to you. And I think the physicians have a responsibility to listen.
Thank you. Dr. Smith, how well are we preparing the next generation of providers to address the maternal and child health needs of Black families?
I wish I could say we were doing it extremely well, but my gut won't let me do that. So as an academician, because I still serve as faculty here at Mercer in public health, I don't know that we do the best job at that. And I say that because every medical student should see what we just saw. So when I looked at that film, I could see my mom, I could see my aunts, I could see my sister in all of that. But at the same time, I went to a pretty large medical school, so there were 288 in my class. So whether the hue of my female classmates looked like my mom or looked like someone of a different race or ethnicity, I still saw them in that too. So it doesn't, in my mind, make a difference whether that, we certainly know what statistics say that the rate for African American women is much worse, but what I also see in public health is the journey and the story is not that different for our Hispanic and Latino moms. It is not that different for our moms that are Caucasian that may be at the lower end of the socioeconomic scale. So with that, I don't know that we're there yet. I think we're certainly on a positive path, and I think this helps get us there, but I don't know that we're there yet. Before this all started this evening, we were talking in the back about what would make this just all go away. And I said I could sum it up in 3 words: just do right. So how would you, want, however you define right? Is it how you would want your mom to be treated, how you would want your grandmother to be treated, your sister, your aunt? And if that's what defining right is for you, then do you have the capacity, the empathy, the gall to do that for every other person that walks on this earth with you? When we can do that, we will have solved this problem.
Thank you. Dr. Warren, I do have a question for you, but I want to reflect before we get too far ahead on what the first three panelists have spoken about. And you know, in the film, you have this high functioning individual who, you know, has a family. She's doing all the right things, quote unquote. You know, she's married, she's got a stable home and a high functioning job, and she goes to the physician with a complaint. As Ms. Prime said, she wasn't heard, she wasn't listened to. You know, I'm a hospital administrator and I'm seeing the physician, you know, doing her charting, and I know the pressures that we put on our physicians to check the boxes. You know, you've got to document a certain way because the Centers for Medicare and Medicaid are expecting us to do certain things. And so on the one hand, you have the pressures of being a part of the healthcare system that physicians and providers are in. On the other hand, you've got that face-to-face interaction that's so important with with the patients, and you've got to balance both of those things. Sometimes we do that well, and other times we don't. And in this example, you know, Nina was failed by her physician, and to that end, I also think that what's interesting is none of the people that were that showed unconscious bias or microaggressions were bad people, right? And I think they depicted that so well in the film. You had the news person that was talking about the young boy being shot. You had the person at her son's school who was talking to her about the dreads. You had her co-worker. I mean, these were regular people, right, that we would encounter anywhere. And yet, each one of those interactions was sort of that death by 1,000 cuts, right? And that is that stress that Dr. Kitchen was referring to. Stress is physiologically linked to negative outcomes. We know that. Stress is a reaction. It's not just a feeling. It is a physiologic reaction that happens in the body. When you're under stress, certain types of cells in your body, they move and they go places and things actually happen. So a lot of times we think about feeling stressed, but it is literally a physiological response. And the longer you stay in that stressed state, the more toll that takes on the body. And it takes a lot to build a baby. Her and her husband were referring to it as their little mango. You know, it starts off as this ball of cells, and then it grows and grows and grows into, you know, a human being. And that takes a lot from a woman's body to get it just right, to get those cells just right, to perfectly form the fingers and toes and organs and all of those things. So you can imagine how when things don't go just right, you have this poor outcome. So with all of that in mind, Dr. Warren, we don't want to forget about patients that are perhaps not in the urban setting like our character was, but talk to us about the patients in rural areas. What are some of the key needs that differentiate patients in rural areas from those in the urban setting?
Sure. A lot of what we see when we talk about rural maternal health is sort of what's portrayed in the film, but magnified and amplified. So it's even a greater extent. So if we're talking about movements toward racially concordant care and the immense benefit that can have for women in rural areas, it's even harder to try to access that type of care, or it's harder to access care in general. So we have a project down in Southeast Georgia that operates in 10 counties. There are only 2 hospitals where women can have babies in those entire 10 counties. And so if you're trying to plan a place just to access care, layering on top of that, trying to find affirming care and supportive care places even more stress upon women, particularly minority women in rural communities. And so it's amplified to a big extent. And so the solutions that we work on in urban can trickle down into rural, but it also has to look at how we're looking at the broader social determinants that impact rural women in particular. So when we talk about poverty, it's even more prevalent in rural. When we talk about lack of insurance, it's even more prevalent. Lack of transportation, it just amplifies everything that's here and places additional stress upon mothers that layers in ways that lead to even higher outcomes than what we see in urban areas, even for minority women.
And really, this question is for any or all of you panelists. You know, we have people here in this room that are from various backgrounds, and we also have people joining us online. So I'd love to hear your thoughts on what can communities do to help prevent maternal and infant mortality?
I'll take that one. Last month I just hosted an event called It Takes a Village, a Maternal Health Expo. And after the event was over, a lot of people were like, oh, I didn't come because I thought it was for pregnant people. I didn't come because I thought it was for people who just had a baby. But the event was for the community. It takes a village. And my thought was, if I can educate the community on how important it is to provide a safety net for that mom, we could make some impact on the maternal health crisis that we're in. When we think about or talk about maternal mortality, a lot of times the community thinks that it's just a pregnancy. It's not just a pregnancy. That mom is still recovering months and months after she's had that baby. So I'm a certified postpartum doula, and so I place a lot of emphasis on taking care of that mom after she's delivered the baby. If she has a 6-month-old and she's calling and saying, you know, I just need a nap, well, I'm gonna go in and help her. I'm gonna go take care of that baby so she can take a nap. But she shouldn't have to hire me so she could take a nap. We've been conditioned as women to, excuse my French, put our big girl pants on and make it work. Like, okay, it's been 6 weeks now, you need to get it together. That's just not true. We have to circle around that mom and make sure that she's safe. If she was strong enough to say, I need help, and her baby is 3 months old, the least we can do is go and help her. Stop looking at, well, I had my baby and I went back to work 3 days later. Well, okay, well, you did and you're alive. Mm-hmm. But nowadays, families are not close. People are away from families, they are away from friends. Some people are in communities that they don't have people that are close to them. My goal is to help teach or educate the community on the importance of taking care of a mom that has just delivered a baby. If that baby is 8 months old or 10 months old and she finally says, I can't do this, the least we can do is go and help. And if it's washing dishes, cooking her a meal, allow her to take a shower. You shouldn't have to hire me so that you can take a shower. And I'm sorry, I just get a little passionate about that because I just think we fail our moms after they deliver the babies. The pregnancy, yes, the delivery happened and the baby was born, but the maternal period is still going on, and it can still go on for another 365 days. We need to step up as a community and help take care of that mom.
Excellent. And remember, if anyone here in the room has a question, you're welcome to step up to the microphone at any time. Would any other panelists like to address that question?
I'll take a stab at it. In public health, in our first generation of how we did work, we looked for programs. So we'd have a program for, to provide prenatal care for moms that may not be able to afford to go into a physician's office for the entire time of their prenatal care. Actually, here in Macon-Bibb County, we have a nurse practitioner that will provide prenatal care, but we also partner with Dr. Kitchens in the residency program so that in about 34, 35 weeks, that mom transitions from us over to the physicians there so that they know who is actually going to deliver them. we are still in a place where we need programs, but I think we also need what we call our PSEs, our policy system and our environmental changes. So what if we had a policy like the dad had to come to the visit? Nobody expects the father to show up at any prenatal care visit. Can that make a difference in taking some of that stress off of a mom? In terms of systems, we just had recent legislation where family medical leave was extended. And that's a great thing. And we cheered that. And we cheered even more when, guess what? Now the dads can take off. But nobody was cheering for the 40, 50 years before when we had it, when it was just the mom that was taking off. Or in terms of environmental changes, what are those things we can do at our agencies, our organizations, to make it more comfortable for that mom while she's going through a pregnancy? When I was a resident, I used to see patients, and I have three children, and I tell folks, you know, when my wife was going through the pregnancy, I'd raise my hand. I'm like, y'all know I'm pregnant too. I'm going through something. But nobody wanted to recognize my pregnancy. I'm still carrying some pregnancy weight right now. 21 years later, I'm still carrying, you know. There's some things that the dads go through, and we may have missed that in the film.
Mm-hmm.
He said, you went to the visit, but you didn't tell me. That's great that you wanted to go. The son was listening to the news, but that son they had is part of that pregnancy process too. Last thing I'll deal with this. When I was a resident, I was seeing, when we had our first child, my wife breastfed. Middle of the night, we were both residents at the time. Middle of the night, she says, I need the pump. I get the pump, hand it over to her. And that thing was so loud. And it wasn't loud. It was just, I'd been up for about 48 hours straight. And I couldn't, I was like, she was like, well, you want to try this? And I was like, fine. If I put it on for 10 minutes, will you turn the thing off? I was post-call, so I'm going to use that as my excuse. So I did it. About 25 seconds in, with tears coming down. I didn't make it 30 seconds. 25 seconds in, with tears coming down my eyes. She never heard another word out of me about that breast pump. You need me to clean it in the morning? I'll do it. Whatever she needed, I did. But let me tell you how that changed me. Because we had to do prenatal care as residents. From that point on, guys had to come to at least one appointment. And I would talk to them about breastfeeding. And some guys, they were bold enough, I'd tell them the story, and they were like, you did that? They're like, man, I could do that. Oh, you can? Okay. Mom, please step out the room. And I had one or two guys that tried it. They then became my biggest breastfeeding advocates because they had to do it. So can we change our policies? Can we change our systems? Can we change the environment where folks that may not feel comfortable being part of that village that she talked about now can become your leaders in that same village? So, and I think those are things that we all can do. You don't have to have an MPH degree to do that. You don't have to have an MD degree or an RN or an LPN to do that. We all can make policies and change our environments that we're in.
And I'd like to add just one more thing. Communities have to recognize that not every family is the traditional nuclear family. And we have to support these moms trying to take care of these kids if there's not a father there. Maybe it's her mom that's helping her. Maybe it's a cousin. Maybe it's you. We have got to step up and help others in our community regardless of how we feel that they are raising their child. We got to help them.
Excellent. We have a question. Please step up to the mic.
Yes, hi, thank you. I have a very quick question in regards to rural health and rural health care. What are the statistics for doulas in rural health care, and how do they fill that gap? Considering that access is an issue, transportation is an issue. Everyone knows in communities, rural communities, small wins are it. So how do we fill that gap, and what does that look like?
So I don't know what the statistics are for doulas in rural communities. I was just talking with Dr. Jacob Warren this afternoon. I was like, I've been looking for you for 2-3 years. But we finally get to meet. But in rural communities, I actually just started after my expo. I was invited to participate in some tours to rural Georgia. I've gone to a place called Cuthbert, Georgia, and went to Oglethorpe, Georgia just this past weekend. And just talking to the residents there about how far they have to travel, what type of care do they have in place for families that are pregnant. But they don't even know about doulas. They've never heard the term doulas. So I would lean on the side that for doulas in rural areas, there's no knowledge of doulas or very, very little knowledge of doulas. So that's part of a plan that I have in my head, is to look at some areas now where some Healthy Start initiatives are to see if doulas are in those areas or if maybe some of the major cities around those rural areas, if they have knowledge of doulas and how do they support those families. The other thing that we have to take into considerations about doulas is that it's not a covered benefit. And so I do have colleagues in Texas and North Carolina, even in like Philadelphia, New Jersey area, because I certified through CAPA. So I know of some labor doulas and postpartum doulas that are in those states. They have state initiatives where doulas are just part of the healthcare. If someone becomes pregnant, depending on the criteria that they have in place, you can just get a doula. So there's no fee for those doulas. But in our areas, as far as I know, people are paying out of pocket to have doulas. So it's become a little bit more monetized. And that's what's been close to me also, is that just because you can't afford a doula doesn't mean you don't deserve a doula. But who's going to pay that doula for that service? And we just don't have that in place here in Georgia.
Okay, we have time for one more question. Go ahead.
Good evening. I think mine is less of a question and more of a thought. I come from education as a background, and we looked at the issue of literacy. And literacy, for many, many years, people looked at it from it was an education problem, but it's really a community issue. So this is not it is medical, but it's far greater than a medical. So we have to look at a collective impact kind of model of how we deal with this and pull this out to how do we educate not only the family that is in this, but how do we educate the community and how does each individual, so looking at that systems and collective impact model to talk about this issue is where we need to go. The community owns it, not just the medical or the medical community or the family in that particular instance.
Thank you. That was a perfect, segue to wrap up here. I know people probably have other things to say, and I'm sorry that we've run out of time. Here in the room, we can certainly continue to have dialogue. Doesn't mean we have to leave, but we do need to wrap up for our online people. Don't forget that there is a survey on the back of your program. Please, please, please fill it out. And for those of you that are joining us online, in the chat, there's a link to the survey. And just thank you everyone for your participation, for your thoughtfulness. Tell others. This is a program that we can potentially take on the road. So this is not your last chance to get in on the conversation. I don't know if our panelists knew that about you. But thank you everyone. Thank you panelists. Really appreciate you being here with us. And we have a gift for you, so please don't go anywhere. We just a small token to thank you so much for spending your evening with us. So thank you very much. Yes. Sure. You can go to the mic.
I actually have two quick
questions I'd like to ask. Are there new breakthrough technologies that will help improve the plight of women of color as they continue to experience labor and delivery?
I'll take that.
Okay.
So one of the things that I think the pandemic helped with, out of necessity comes ingenuity sometimes, is with the way we see our patients. So sometimes we can do virtual visits, which gives patients better access to us. So I think that that's one of the technologies that's helping. And actually, I'm going to a conference this weekend, and one of the vendors is asking me to come by to look at their monitoring system for women at home, so that we can actually see how their babies look when they're at home. So I think that, yes, there are some future technologies that are definitely going to be helpful and that are emerging.
Okay, thank you so much. Also, how can we as civic leaders support you in your endeavors to spread the word about this? How can we do that in our communities as civic leaders?
I am very, very happy that our legislators in Georgia actually expanded Medicaid to 6 months postpartum. That is one of the biggest things that we needed to do, was to expand health care just a little bit, so that these women can not only get their prenatal care, but then we can take care, once they've gotten out of their postpartum period. For many years, I wasn't able to see them because they had no health benefits. But now they can come back, or I can send them to someone to take care of their blood pressure, so that when they get pregnant again, they won't have those issues that they had in this pregnancy, or take care of their diabetes. I think that civic leaders can really support the healthcare community by helping us take care of these patients, by expanding benefits just a little bit.
Okay, thank you so much.
And actually, if I could just piggyback on that, so at the most recent legislative closure, they actually extended these benefits to a full year. So we had 6 months, but now it's going to be a full year postpartum for those Medicaid patients. So that is a huge win. It'll give us that much, longer to maintain that health care after pregnancy. And then I'm also going to piggyback on your first question, just because I can. In terms of innovation, it may not be, this is not a technology per se, but there is a different model of prenatal care called centering. Centering pregnancy is group prenatal care. And it sounds a little strange, but the data that's out there shows that women that have this group prenatal care have babies with higher birth weights. Even if those babies are born prematurely, they still have higher birth weights, and that is critical. That birth weight is almost as equally as important as the gestational age. So centering pregnancy is basically a group of women, maybe 10 to 12 women that are due around the same time, and they go through prenatal care together. And it also has an aspect of ownership. When they come in to have their visit, they actually come in, they're taught how to take their own blood pressure, how to weigh themselves and record it, and check their, dip their urine in places that still do that. And then they have a brief period of time with the physician where they listen to the baby's heartbeat and do the measurement and all of that. But the bulk of the visit is spent in a group setting where they have some snacks. They have communion with other, women that are going through the same thing as they are, but also it's a lot of education. And it's a mixture of women. It's some first-time moms, it's some moms that are not the first time. So the learning is not just, it's not just the physician or the nurse practitioner that's doing all the talking and teaching. They end up teaching each other, and that's their community. So we've been talking a lot about having that support system and community, and as they go through the pregnancy, they actually, when somebody doesn't show up, it's like, wait a minute, now we're missing so-and-so, let's call and check on them, and it ends up being that another support system, or for some of them, their only support system. So we have stopped and started centering pregnancy within our health system, but that's something that we really need to figure out, how we can do that here better, because it's just another option. It's another, model as opposed to that individual quick visit where you're just in and out and it happens really, really fast. So, all right.
I suspect these folks want to go and end soon, but just a few thoughts and maybe a question. So Dr. Smith, I really appreciate your comments. I have a daughter who just turned 9, and I remember when my wife was pregnant. I was, West Coast, so we're a little bit more evolved, and she was like, "You better never say we're pregnant." She was like, "You can say we're having a baby, but we aren't pregnant." This is like, you're not the one doing all this. I was like, "That's fair. Oh, I'm good with that." But to your point, I think the importance of the unit, whatever that is, spouse, partner, family member, that support network is so critically important. Dr. Walker, I'm all over centering. We did it in Oakland. We need to do it here. I think it's so critically important. And I just want to speak to, we've talked a lot about just some of the all the different variables that people encounter and challenges really that they experience through prenatal, even before they're having a kid, but also during that pregnancy period and post, particularly in rural areas as we get in the further out. So centering, while I think is really important and great, we've got to figure out how do we do it in a way that doesn't further the disparities that people are already experiencing. So broadband, somebody asked earlier, what are the things we can do? Getting coverage is really, really important, but coverage is not access. So sometimes you can get insurance and you can't find a doctor who will take it. Or you got insurance and the doctors doesn't have available appointments because they're oversubscribed because they're not enough. So expanding the network so that we're using all the different parts of the continuum, doulas and others, NPs, PAs and others, but also broadband, right? So if we can get greater Wi-Fi capabilities in some more remote areas, when you do centering, people can't always drive to that place. That's what we've learned so much during the pandemic. We've got to be able to bring some things to people in order for them to have that. So I would say if we can continue to look at that, and then I just yield to you all as experts. I don't, and I know as a practitioner, like I said, we don't look favorably on the fact that we're so low on the list. I mean, I was born and raised in Georgia, and I'm like, good grief, I knew it was a miracle that I was born, but I didn't know it was that much of a miracle. Now, I don't want us from 5 years from now to be having this same conversation and saying we're still at that place. It's a list of 50 people, somebody's got to be number 50 and 49. We don't have to be it. So I would love to hear if you have some thoughts on what are the top 1 or 2 things that we already know. We're going to continue to research and study and try to figure out how we improve these things, but are there, if we did X and Y or A and B, we will make a dent in this challenge that we collectively face. You have thoughts on that? I'd love to hear.
I would say healthcare coverage before pregnancy. If I could wave a magic wand to solve this, it would be ensuring that all women have access to healthcare before they become pregnant, because the way we treat women is as if their pregnancy and health-related concerns start at pregnancy, and then until very recently, they ended 6 weeks after. And that's not focusing on the whole health of women, and having the opportunity for women to be healthy going into pregnancy would be massive. Perfect. So I'm avoiding saying a certain phrase, but I think we all know the phrase that I'm not saying has expanded in it. But yeah.
Perfect.
I think that what we're doing today is actually one of the things that we need to do is to talk about these biases that everyone has. Earlier this year, or last year, Dr. Walker and I both had to do an unconscious bias video series and answer some questions when we were renewing our OBGYN certification, and it was eye-opening. It really is. And unless we have everyone to kind of open their eyes about our own biases, and just because I'm Black doesn't mean I don't have biases, I do. And we need to recognize those. Once we recognize those, if we understand that we have biases, our outward projection to other people is a little different, and they will feel more comfortable coming to us as healthcare providers. So I think it's really important that we talk about these things.
Thank you.
And to that, I would add, in terms of if you had to name one thing, certainly access pre-pregnancy, but one of the social determinants of health is poverty. And if we can address poverty, then that will help quite a bit. In this film, The young lady worked as an attorney at the top of the socioeconomic scale and still had issues. But just if you don't, that doesn't mean take anything away from the folks at the top of the ladder, so to speak. But we can also make sure that the distance between the rungs are not so steep. So if we could, one, address poverty, two, we have great access to care in our community across the region. But great access doesn't also mean great quality. So make sure that there's quality with that access. The young lady in the film had access to her physician, but there were some things that just weren't clicking between the two. And then the last one, which was, the question was asked about what can our civic organizations do? Help our community members not miss opportunities. And as an administrator in the health department, that's one of the things I harp on all the time. If we have someone that comes in for one thing, if we have a young lady that comes in that's over 40 and has no insurance and comes in for family planning, did we mention to her that we have a breast and cervical cancer screening program where if the clinical exam is done with us, we can pay for the mammogram? Well, they didn't come in for that. Yeah, but they left without so much more. That's the problem. Help our folks not miss those opportunities. As healthcare providers, we shouldn't have too many missed opportunities. Person comes in for one thing, you're noticing the child is there. Did we check that child's immunization record while they were in there? It takes 5 minutes. Or their eyes. Ran a vision clinic today. I'm blind with all the folk that were coming in there. Folk kept calling. Now I gotta find a way to put somehow, board member, come up with a vision clinic at the health department. But yeah, those missed opportunities. How, if we see the problem, let's address the problem. So we can't be blind to those problems. And the very last thing is we make these lists of these things we have to do. Keep in mind what LIST is an acronym for. Left out, ignored, set aside, turned away. So if you make a list, do something with the list. Because many times we do it and then it gets moved from the, my pile here to my selected pile to my neglected pile. So we have to do something with those lists.
All right, we have another question or comment.
Oh, yes, thank you. My foot is a little compromised, you all. But how does the medical community overcome what I call, confirmation biases when it comes to diagnoses that are not clear, black and white? I want to elaborate a little more. I found myself in a community of people who had to find support within ourselves because we had non-traditional diagnoses. And if you couldn't get beyond A, you couldn't even move to B. And also in this group, there have been several women who have either almost died or lost their babies only because their blood test came out negative or their urine test was negative. But physiologically, they were pregnant, but it was in another area within the body, for whatever reason, not producing the hormones that it should. It has a name, Cryptic Pregnancy, but that has become a community that has to take care of themselves because of the definitions of what pregnancy is. Then you can't get past the door to get into the proper care. One, because either somebody's afraid that if they further your care, what someone else is going to say. I've heard that. And, well, you can't have a pregnancy with a negative test. I can go to the dollar store and buy a test. Is that the range of care? So what can care providers do to get past the definitions, which I was told also, the insurance won't let us do anything else without a dollar store test. Basically, that's where I am. How do you get past the definitions that prevent the care that's needed for non-traditional diagnosis?
That's a tough one. I think that it is very incumbent that, all healthcare professionals listen to patients, number one. We had already discussed that. Number two, yes, we are very much ingrained in what we were taught. I mean, we are taught diagnostic labs and tests, and that is what we are comfortable in. Sometimes we do have to step outside of our comfort zone to care for patients appropriately. And I think that developing a dialogue with your physician, with your healthcare provider, opening yourself up and asking them to listen to you is probably going to combat that more than anything. Having a dialogue, having a conversation, having a relationship will help with healthcare more than anything.
Yeah, and if I could add, I mean, I think, you know, and this is unfortunate, but if your physician is not meeting your needs, you have to try to find one that is. And so for every closed door that you go to or through or up to, you know, that's not the one for you, you know. And so some of that is trial and error, trying to find that person, that physician or provider that will listen to you. That's not fair. All of them should, but we know the reality is that all of them don't. And so many times we try with this one, you know, physician, and when you should say, okay, clearly I'm not going to get the help I need over here. Let me go over there. So, I mean, that's not a great answer, but I think you just, you know, have to find that physician that you click with and that understands you. And again, I think going back to what Dr. Warren said, that goes back to not just going to the doctor when something's wrong, but it takes time to establish that relationship. So you've got to have that primary care provider that you go to for well checks. And because the more that you see that provider and they know who you are as an individual, when you do come in with that, you know, non-traditional problem or something that's not in the textbook, then they're more likely to fall back on that relationship that they have built with you over time. And they know, well, I know her, she's not crazy. Let me think about this some more, as opposed to, you know, someone that you don't have that rapport with. So I think that's another thing we want to stress. All right, this has been fantastic dialogue. We could sit here for much longer and continue to have conversations. Again, thank you to our panelists. Again, we do have something here for you. I don't know if these have names on them. Are these going to anyone in particular?
Oh, thank you.
Thank you very much. There are also some refreshments outside, I believe, so everyone please partake of those, and we appreciate you coming out with us this evening. Thank you very much.
All right. I've had a very long day anyway. Thank you.
Hey, good to see you.
As always.